So, thank you for joining us for this panel discussion on addressing the unasked and reinventing healthcare through positive deviance. In this event, we'll delve into unaddressed issues and overlooked aspects of healthcare, sparking curiosity and driving change through questioning norms. This panel discussion is not just about envisioning the future, it is about creating it. And we invite you to engage via the chat as our panelists share insights, challenge preconceptions, and ask and offer answers to the difficult questions that lead us to a better healthcare system for all. Together, we will explore how asking the right questions and embracing diverse perspectives can lead to breaking innovations and more effective healthcare system. And before I introduce our panelists, let me just orient you to the event format. We have created a preset few questions I'll ask of the panel. However, our goal is to have a conversation that retains focus on the purpose of the event, but organically develops. My role as the moderator is to keep us focused with a little bit of allowance for some deviance because we are ruckus makers. Lonnie's going to moderate the chat, so please feel free to add comments and questions there. And in fact, I encourage you to take a moment and introduce yourself in the chat now. Share your name, where you are, or where you work. Offer your email or your LinkedIn URL if you would like. We will pause twice to allow Lonnie to update us on the discussion in the chat. So around 11:50 Pacific time, which is 2:50 Eastern, and then again around 12:30 Pacific or 3:30 Eastern. And if you caught those times, yes, this is a full 2-hour event. As our panelists, when we were planning it, we recognized that we would not do the topic justice with just an hour, especially with 4 panelists. We needed 2. If you need to leave us, please know that we are recording. You will get access to the full recording and the event summary. I have spotlit our panelists to enable our focus to be on them. I would love to have the full Brady Bunch window showing, but doing so makes editing of the recording difficult. And this way we can be really focused on our panel. But we would love to have you join us in the chat, and Lonnie will be there with you and facilitating that. And then finally, unlike our other events that we host, because this event was already 2 hours long, we did not include our typical collaborative conversations, or otherwise known as speed networking, to follow. Though I am happy after the event to keep the Zoom open for a little bit and engage with anyone who would like to stay and continue the conversation. So I'll announce that as we close again as well. So let me introduce our panelists. And yes, we are all technically doctors, either via MD or PhD, but each were asked to join this conversation based on the work they are doing, not the letters after their names. So let's start with Zeev. Zeev is a seasoned healthcare executive and the author of Reframing Healthcare and Beyond the Walls. He has been on a multi-decade journey to humanize healthcare, and his pragmatic approach to creating actionable, strategic change are based on hundreds of examples of courageous entrepreneurs and bold leaders who are showing us that it can be done. And Adrienne Boissy is the Chief Medical Officer for Qualtrics, is at the forefront of measuring and enhancing patient experience. Her leadership in improving communication in clinical settings and her ethical insights into patient care have positioned her as a champion for the humane treatment of patients and the art of conveying truth in healthcare. Todd Otten is a family physician with a rich background in patient care and healthcare leadership. He co-founded Our Quadruple Aim and co-authored Ripple of Change with one of his patients to challenge and improve the industry's status quo. His personal journey through burnout has fueled his mission to inspire positive disruption and empower stakeholders to create waves of lasting change. And John Silver, with more than a quarter century of healthcare experience and a fresh, sustainable economic model for a true health system as an adapted public utility, is a driving force behind nurses transforming healthcare. His innovative approach puts nurses at the helm of patient management, advocating for safe staffing levels, independent NP practice, and a shift from a disease-focused system to one that genuinely prioritizes health and healthcare in every community. All right, team, are you ready for the first question? Excellent. So we're going to start with the title of this event. It's the Unasked in Healthcare, Driving Change Through Curiosity. So I'm going to ask each of you, what are we not asking, or perhaps just not asking loudly enough? Who would like to take that first?
I'll go.
Go, John.
So I think the biggest issue I've seen when I started my work on systems level change was that there were never any clear goals of what we wanted to have as the end picture. In other words, there's a lot of innovation talk out there, a lot of it's process level stuff. And I haven't seen really a coherent picture of what do we want to end up with. And to me, that requires that you define the goals of what a healthcare system should be.
Thank you, John.
Yeah, John, I'm going to just pick up on what you said because I think that's really, I think you're spot on. You know, Denise, I think the question we're not asking is do we actually want a healthcare system? Because we have a healthcare industry. There's no question about that, and it's growing by leaps and bounds. And we could argue whether it's good or bad, but it's huge and it's large and it's in many ways successful. What we don't have is a healthcare system. And I think that's the question. And I think, John, it really picks up on that. I mean, what is it that we really want? Are we after an industry? Or are we after health? And, you look at countries like Costa Rica that are just a fraction of the size we are, with a fraction of the amount of resources and money and intelligence and people. And yet they asked that question and they answered it. They wanted a healthcare system, and they're getting outcomes that in many ways far surpass our outcomes. Again, so I think I really think it's a question I have not heard asked is, A, do we have a healthcare system? And so what do you mean by that? And do we want a healthcare system?
I love that. And Zev, I also often talk about the industrialization of healthcare. So I'm glad that you pulled that thread in there too. Yeah. Adrienne or Todd? Oh, go
Sure.
Todd.
Yeah, sure. I'll chime in. So I often joke that I'm a troublemaker when I introduce myself, and there's probably some truth to that if you read the book. Some of it had to get censored, I suppose. But I think the reality is we need to ask questions or be very forefront or forthright with how do we blow up silos? How do we knock down some of the walls and go beyond the walls, as Zev has said in his wonderful book, to collaborate, connect the dots, and what have you. And I think that's a big part of the reason why everyone's here today is that connectivity, those networks. So my big question is, how do we blow up silos? Obviously, metaphorically speaking.
Well, I have more than one question. It doesn't feel fair to ask. And as I'm sort of looking at the list, if you forced me to pick one, which I know you are trying to, what I would say is, why are we chasing extraordinary quality, safety, experience, and value when the people in our systems feel like leaving it? What is broken about that equation? And it seems we're very good at describing it. We talk about statistics there. I am curious about the interventions that we're seeing that actually stick and work. I don't think there's any more research that needs to be done around the service profit chain of a good employee experience drives a better experience for customers and patients. But then why aren't we in a crisis conversation about the environments we're subjecting people to, extraordinary people to, in healthcare, when we expect extraordinary results?
So if I can add to that, Adrienne, my name is Dr. Lord. I'm with the International Caregivers Association. We're the first to come out with a systems approach to change dementia care that affects the entire healthcare system. We have a system that can actually bring the changes that you're all looking for, actually save money, and have people respected and valued for what they bring to the workplace. Honor and respect those who are actually living with dementia in the case that we're focusing on, but it would apply to everyone. I see literally, I was surprised last week to read about the bullying that's going on in just the nursing industry. That needs to stop. With the system we have, that does not happen. People don't want to leave their work. Why? I'll just give you an example. CNAs who do the bulk of the work, they work for 6 hours, but they get 8-hour pay. So they come back the next morning. You can't get rid of them. We make sure that everybody knows who they're working with, what the purpose of their work is, how they can help to change the entire healthcare system. They're happy about that because it gives them a life purpose. We treat them as professionals, not job workers. It's remarkable. So sustainability in healthcare is at a tragic point right now. And unless we change and look at systems like we created, as the first one in the world, I'm sure there will be more to come down the pike. But it's remarkable, and people should look at it. People should apply it. Let's change it. Let's do something. Talking about healthcare and the problems in healthcare, and without a solution is a waste of time. I'm not interested in that. I always
you
say to people, if you have a problem, bring it to me, but bring me at least one solution.
Yeah, beautiful. And on that note, thank you so much for your contribution. I appreciate that. And I hate to ask this of those who have joined us, but we're going to very much ask you to stay in the chat and we'll focus on you when we take breaks. There are so many voices that should be in on this conversation. But for today in the verbal conversation, we're going to focus on John and Todd and Adrienne and Zeev. But thank you for that contribution. I thought that there was great value in what you shared. And I want to turn to our panelists and ask, is there anything you'd like to contribute to what was shared there?
Yeah, actually, I would to talk about with Zev. You know, if you read Tulgawande's article in the New Yorker on Costa Rica, which I certainly did, it seems the biggest innovation they had was they just connected public health with the medical practice in the field. And, you know, that is just one branch, I think, of what we need to do. Because again, we're not the size of Costa Rica and we've got you know, a gazillion more people. To what Adrienne said, I think if you look at this systems level down, there are different silos of power down through healthcare. And I think the disconnect to the providers and why a lot of them are getting so frustrated is what they've termed moral injury, in the sense that we're not allowed to practice as we're trained to practice. And that applies to nurses and physicians. And the whole system has become geared toward throughput for speed and profit. And if you're a physician and you have to see 40 people a day, you know, it's really tough to pack everything in you want to pack in 12 minutes. Same thing for nurses. If we've got too many patients to take care of, if it's 7, 8, 9, 12 patients we're taking care of in acute care facilities with, you know, we've got people with higher morbidities now coming into these systems, and it takes time. And we just don't have that in this system.
Yeah, I know we're going to probably move on to another question, but I think, Denise, your question about the unasked questions is really, really important. We all get very, very focused on what we're interested in, what we're focused on. And I think to take a moment just to step back, I think this is a really important, you know, conversation. I think, you know, sort of what Adrienne was saying before, I've got lots of questions, unanswered questions. I mean, I think, you know, one is why, again, are we still only spending 5% of all healthcare expenditures on primary care when we know, you know, primary care is the key to any system of healthcare, and yet that and we're far below other developed nations in that regard, and it's probably one of the reasons, you know, why we're seeing longevity in this country decline. We're the only advanced nation, the only one in which lifespan is decreasing, which is, you know, absolutely ridiculous. You know, another question is, you know, we all talk about evidence-based medicine, but we know that the evidence is that most of health outcomes have nothing to do with clinical care. They have everything to do with the social determinants of health. And so why aren't we spending, you know, again, more resources on the social determinants of health? You know, so I just think those are, you know, I think if we don't do what you're saying, if we don't ask those really fundamental questions, and to what the speaker was saying before, we want some answers. You know, this isn't just about raising the questions. The questions are there to incite some thoughtful response and some, I would say, action with integrity. So I do think what you're doing here by asking these really fundamental questions and sort of, you know, again, we're at a, you know, 30,000 feet level, but sometimes, you know what, you need to actually have that. You need to be above the crowd. You need to be looking down and really asking some fundamental questions and issues and challenging the system in that way.
Go ahead, Todd.
And if I could just add on to that, I think that's brilliant, Zev. And I would take it one step further, that we need to not only ask the questions, but when we find positive examples and or solutions, we need to celebrate and highlight and prop those individuals up, shout loudly what they're doing, and hopefully we can create, to coin a phrase, ripples and waves of change, if you will, pun intended. As an example, I just started working with an emergency room physician group. Why would a family physician be working with an emergency room physician group? Well, because they're physician led, they're forward thinking, they embody the quadruple aim, and they do wonderful, imaginative, innovative things that I want to be a part of. And not only do I want to be a part of it, I want to learn from it and then shout that out to the world. And if you're interested, the name of the group is Emergency Care Specialists. It's no surprise. I posted it now, and I'm actually in the office here. There's no Navy stuff behind me as usual. So it's a little bit different. But yeah, I think we need to ask the questions. And then when we find what we think are good answers, get loud, get really loud.
I'm gonna pick up that thread. I think about oftentimes the disconnect that I see as a proponent of big evidence based care, bringing rigor to the work that we do, measuring outcomes with numbers. And I think there's a lot of fabulous work that exists in small pockets. But I want to pick up maybe a little bit of what Denise is challenging us to think through, which is humility. In order to learn from others, whether it's a patient in front of you or another organization you never heard of, or a model of care that's different from you, you have to be willing to accept the premise that you might have something to learn, that you may not know best, that what you have done works for you, and that others have a lot they might contribute through their diversity of not just culture or ethnicity, but of thought and of model of practice. I mean, you don't have to go to Costa Rica to see models of that in the US, right? They have like Iora Health did this. They took people from the community and trained them up in healthcare, but they were empathic and they were hired for their ability to be a local and understand the community challenges. And then those were the people that went to the grocery store or taught them how to ride the bus. You know, these models exist and they're not new. They have been around for a long time. Some of what I sense actually is that we want to continue to work on the good work we're doing in our organizations. And occasionally we go to national meetings and learn and try to bring that back. And yet sometimes still at an individual leader level, I still see a lot of, this is a little bit of my fiefdom. I know how to do this. We'll do it my way. You know, this is the way we're going to move forward, even when there's evidence to the contrary, that may not be the best path. And again, you know, being a neurologist and still taking care of patients, like I see this sometimes, and whether it's the human brain likes to love our ideas or it's something else, I'm not quite sure. But I do think we have to have a learning edge that recognizes we may not know best, and great ideas can come from anywhere. And having the humility to reach out and ask, I think, is something where I see us really take off and share ideas. A good example I can think of, I was at a conference recently and we were mentioning best practices in the value-based space, and some people had never heard of them, and they were papers written 20 years ago. And so it's also about modeling being a student of the work. There's no point in Zeev writing a paper or, you know, my colleagues here, Todd, writing a book, like if we don't go tap into those resources. So I'll take a deep breath and pause, but I think we have a responsibility to learn from each other and be students of the work.
If I could add one quick comment from the chat that I think is related to what Adrienne was just talking about. Andrew Lensman wrote, being comfortable going from expert to novice is a critical skill for building the future. So I think that's a nice way of framing what Adrienne was just talking about.
And Lonnie, I went ahead and spotlight you because what Adrienne was just talking about is what we're trying to create. That ability, there's so many different groups, physician groups, nursing groups, others who are saying, I've got the answer. And we think they've got a part of the answer. But healthcare is a complex system and no one is going to have the entire answer. And how do we create a network of networks? So one, we can integrate our solutions forward to truly create what we need going forward. But more importantly, we can listen and learn from the others, because when we say a little bit of this and a little bit of that, now all of a sudden we've made something that none of us considered before.
It looks like we all want to say something at the same time, which probably isn't going to work, I suppose. I just wanted to say, Adrienne, that was brilliant. I love that. And I totally agree with you. This journey I've been on the last year, I have learned so much from so many wonderful people. And I don't feel like there's one specific solution to this wicked problem. It's going to come from a lot of brilliant people working together. And I think another important part to that is there has to be give and take. We have to learn that our solution, although we may think it's great, might not be what's needed, right? And maybe we need a little bit of Adrienne's and maybe a little bit of John's and maybe a little bit of Zeev's, and we put that together in this magic sauce and hopefully come up with something incredible. And it can be humbling at times, but that's okay. That's okay. And frankly, the position I'm in right now, there is no job description for what I'm doing. I am not afraid to fail. I want to go forward. I want to learn from this. And I hope this experience is able to teach others and we can get a lot of benefit out of it. I think, sorry, John, I might have cut you off. I didn't mean to.
Oh, Todd, you can cut me off anytime. I just wanted to follow up a little bit on Adrienne and Zeev. And it's not just things that we're doing here that some of them are working. Around the world, there are little pockets of innovation in how things have been addressed, or combinations of work groups, or, you know, from Australia to Canada, the US, England, Germany, France, South Africa, India. I studied health systems on 3 continents. And you see things in the Argentinian system that you're going, geez, why aren't we doing this here? And then when we come here, we see a lot of innovation in things like HRSA grants and university research projects addressing things like Black maternal health or maternal child health. But they're not sustainable, and they're not systems driven, and they're not an expectation of whatever we want to call what we have now as a priority. And I think that's one of the problems we have is how do we fit these, nursing did 15 years of research in delivering healthcare to rural communities because that's kind of in our DNA to start with back in the 70s. But we could never figure how to put that into a system that was driven by you have to make X amount of profit or we're not going to invest resources. I got to end with that.
Yeah, it's interesting again, going back to this issue of questions. So I started to, and Adrienne, I just picking up a little bit on what you were saying, I started to ask myself this question about 10 years ago. What were the divergence? What were the positive deviants doing in healthcare? And started to look up people like Rashika. I had my first conversation with him in 2009, and then interviewed him many times over the past 10 years, and hundreds of others like him who were, I would say, divergence. Definitely, I think you would agree. Positive deviants. And my first question was, well, how are you thinking? Like, what are you doing, and how are you going about it? And that actually was what led to the first book I published in 2019. It was Reframing Healthcare, which was there's a pattern. Here's what they're all doing, right? And I was the hope there that it would be instructive to others who wanted to also deviate and diverge. And then I started to ask myself, well, okay, I sort of get a sense of how you're thinking, which was really super helpful to me, but and others who have read the book. But then the question was, well, what are they doing? Which I think is a different question. And to speak to what John, you were saying before, what I discovered in that exploration, so now I've conducted over 450 in-depth 1 to 2 hour interviews with these positive deviants over 10 years. And, what I do is I transcribe those interviews and then I study the transcripts. So these are, this is a lot of time and a lot of effort and a lot of thoughtfulness behind it. And what I saw was that they're all doing the same thing, which is, and again, I share this because I do think it's instructive, that they all are leading with a humanistic cause, which, and there's I won't go into it, but humanism isn't some sort of, philosophic stance. It's actually very, very defined what that means and how they define it and what they're doing. And I share that in the book, but that's not enough. What I saw each of them doing was coupling that with 2 other strategies. One was they're using the state-of-the-art technology and digital, and they're not using sticks and stones. They're not using Excel spreadsheets. They're using state-of-the-art. They're fighting fire with fire because everyone else is using state-of-the-art digital. So that's what they're doing. And many times, many of them are literally on the cutting edge of digital and data and technology. That's one strategy. The other is business model transformation. So they're again fighting fire with fire. They're playing the game to win, and so they're incorporating state-of-the-art business model transformation, whether that's around payment reform, really getting into Medicare Advantage, or it's partnerships or other forms of business model transformation. And that was the pattern I saw. And I think, not all of them have been, greatly successful, but I would say the vast majority have been. And I think it's because of that sort of tripartite strategy. And so for me, what's helpful is to say, well, and I talk to a lot of leaders, and the question is, well, what can I do, or how do I succeed, or how do I make this sustainable? How do I, and I find what the others have done to be hugely instructive in that way, because they're playing to win. They know the game. They're really realistic, and they're using the technology and the business model in a humanistic way to transform healthcare. And that gives me a lot of hope as well.
Yeah, I love that. I talk a lot about operationalizing empathy, right? And it really, I think, resonates with where you're going, and appreciate you sort of pushing the field with that level of diligence and rigor, that this is what the positive deviants are doing. I think I often think about how do we bake it into processes and systems that feel more caring to the people within them. And maybe just because it's top of mind, even if you forego for the sake of your sanity, right? Like transforming the business in its entirety, or, carving off these huge pieces of work to be done. I do think there's a lot of innovation that happens locally. And sometimes I feel like the cracks still teach us something about where we have ongoing opportunity. For a quick example, I had labs drawn recently, and despite having an appointment, I still had to wait in line, even though I had an appointment. And then, right, they still say my name in an open lobby with lots of patients. And then as I'm sitting there, the woman next to me has a jar of pee next to her own sample of urine sitting next to her on a chair in the lobby. And I have to say, I was infuriated by it. You know, the fundamentals, we cannot fit, you know, everybody's abuzz with digital transformation and AI. I think it's great. It will happen. And yet, to me, this was a fundamental violation of human dignity that has no excuse. Absolutely no excuse. Shouldn't be happening today in 2024, 20 years after the IOM report calling for patient-centeredness and 6 different improvements for healthcare. I'll spare you the other example, but I worry, and I'm curious about how others see, right, these big lofty ideas we're talking about and the cracks we still see in the system in terms of how these systems are making people feel. What you might have seen that's really successful and something we could all learn from to take to scale, because it broke my heart.
You know, Adrienne, I moderated a panel last week in Vegas, and I opened up by just asking that question of how many of you, because the 3 panelists were telling their story of drops in the healthcare system. I asked the audience, how many of you, when I ask you about a patient experience and ask you your patient experience, have a story you could share, right? That something immediately comes to mind. And I asked, so how many of those are positive versus having been dropped? And of course, most had a drop. And for many of us, some of those drops may not be life-threatening, but I know, like, my own drop led me to have multiple pulmonary emboli and end up in the hospital. So we are risking the lives of our patients because we're not looking at them as people. They're widgets, to some of what you were sharing there, Adrienne.
Well,
I want to talk a little bit about technology, because you brought that up. You know, over 40% of the counties in Texas don't even have a PCP. A lot of places in this country still do not have internet and Wi-Fi service. And to give you my own example, even though I'm in an area that's got tons of both, I had surgery done on a spermatocord, and my follow-up was by Zoom. This was during the middle part of COVID. And urologist says, all right, stand up and show me the surgical site so I can evaluate it. And I'm going, yeah, that's not going to happen. I'm not going to sit here and just expose myself on over the internet so that, you know, I think we have to realize that at a really critical level, healthcare is a practitioner and a patient. And we need to protect that with every ounce of our fiber, that we're not just throwing technology out there because we have it, that we're really applying technology to meet goals of what we're trying to achieve in healthcare and use it, as Zeev said, humanistically.
Well, and John, I just want to identify that you used a key word there, practitioner, and we argue over words, physician, provider. It drives me nuts. We do it in the patient as well. Are they consumers? Are they patients? The time and energy that we spend on arguing about words, when fundamentally the patient really doesn't care. The person on the other side who is giving me care, I care about their qualifications, who they are, and that they're listening to me. I don't really care what you call them. They're my practitioner for the moment.
Well, I do think it's important. I have tremendous respect for medicine. Nobody's trying to wipe medicine off the map here for care. But we have to understand that it's going to take all of us working together to the scope of our practice with what I call intentional design of what we're trying to do to be successful. And, you know, this isn't 1926 anymore. We have multiple disciplines practicing at PhD and doctorate level practice. We need everybody's skills. And we can't set up systems that just have continuous micromanagement of everything that's going on. So, you know, there has to be some trust, and fields have to realize that they need to police themselves in a sense and be, you know, aggressive in doing that.
I saw your hat, Todd.
Yeah, I've been quiet, so I'll chime in here a little bit. This is all music to my ears on many levels, and there's so many things I wanted to kind of jump in on. But I think what I really wanted to talk about was the power of synergy, and talking about synergy and how synergy can really challenge some of the existing status quo, if you will. And I'd like to speak to an initiative that I think you're all familiar with Medicine Forward. You know, initially Medicine Forward was really a grassroots doctors organization, but in the recent past, we realized we can't change some of these mountains of problems by ourselves. we need everyone working together with some give and some take to really move mountains. And I think it's possible. Again, it has to be learning from others, as Adrienne said. It has to be the give and take. There has to be understanding. There has to be trust. There has to be forgiveness at times, I suppose, when you make a mistake. Or maybe if I accidentally drop an F-bomb. I was in the Navy, so we can't forget that. But I want to give an example of a project that we're moving towards with Medicine Forward. And I think most of you are aware of it, but it's called Prescribe Hope. And we're building towards an audio documentary to really pull back the curtain on the mental health decay that's going on in this country, and even more so, activating towards safe haven initiatives in all 50 states. Because the reality of it is, if we keep going at the pace we're going of losing clinicians, whether we use the word provider, nurse, physician, whatever, there will be no one left to care for the human beings that we are trying to care for. So everyone's aware that I'm a big fan of the quadruple aim or the quintuple aim or our quadruple aim, whatever you want to call it. But back to Zeev's point, we have to be paying attention to the human beings that are involved in this process. So I'll stop talking at that point. I always feel like I talk way too long, and then I go back and watch these things, and it's like 30 seconds.
Yeah.
But everything you say is important.
I don't know that I'd go that far, John. I mean, I was talking about F-bombs at one point in there.
Zeev, were you about to say something?
I mean, there's so much to say, and I feel very much like you, Todd. It's where do we take this conversation? What direction? There's so much to say, and Adrienne, it's just so funny. I was thinking about, like, we're not rational beings. We're right. This behavioral economics has demonstrated that we're clearly not. And so we have our biases, dozens and dozens of human biases. Mine is recency bias. So I get caught up in the last interview I've done with the last exemplar. And I do think I actually do think it's relevant, which is why I'd like to share it briefly, which is, and I hope this is helpful, Denise. We talk about, Todd, you were just talking about and John, you as well, talk about the loss of people in healthcare. We just, before we got on, someone shared a statistic with us that 25% of medical students have no plan of ever practicing medicine. And I suspect that number is growing. And we know that nurses who go into healthcare today last for a couple of years and then they drop out and do something else. And one of the major reasons for that is burnout and overwhelm. And it's largely it's not that we have people who don't want to work hard or anything like that. Nothing like that. But the problem is that the nurses in the hospitals in particular are subjected to overcapacity consistently. So I interviewed a guy named Eugene Litvak. He's a mathematician, PhD. He's at the Harvard School of Public Health. He's been doing this work. Talk about perseverance and commitment for nearly 30 years. And I heard him lecture for the first time 25 years ago. He was already world renowned at that point. He had already figured out what was the cause for overcapacity in hospitals. And it has nothing to do with what you would ever think about. Why are EDs crowded? You would never guess why. And he mathematically studied hospital systems, looked at patient flow, and figured it out. He figured out the root cause problem, and he figured out the solution. And he then deployed it in a handful of hospitals that saw phenomenal results as a result of it. And so the nurses, you didn't see overcapacity. You didn't get nurses taking care of 2 to 3 times the number of patients they could. And by the way, what he showed was, not him, but others have shown that, let's say a nurse is supposed to take care of 4 patients on a floor. Let's say that's the ratio, 4 to 1. If you had a 5th patient, mortality for every one of those patients goes up by 7%. If you had a 6th one, it goes up to 14% for every one of those patients. And then after that, mortality is exponential. And, so clearly, and this has been demonstrated, people are dying because of overcapacity in EDs and hospitals, and nurses are getting burnt out and demoralized, as John was saying before. And we're losing people because, for the simple reason that it's just the capacity is just overwhelming, and it's not right. And so the question there is, well, and so Eugene figured it out. If you're interested, I could shorthand his solution, which is actually really elegant, really simple, not that complicated, and doable for every hospital system. And I said to Dr. Litvak, I said, Eugene, I heard you talk about this over 20 years ago at the Harvard School of Public Health when I was sitting and listening to your lectures. And what have you been doing for 20 years? Like, what's going on? Like, how come every hospital system isn't using this? And how many are? And he said to me, very few. He shared some examples, Cincinnati Children's and a handful, the Mayo and a handful of others, but the vast majority are not. And so you're seeing the overcapacity, you're seeing the overwhelm, you're seeing the burnout. It's the reason why people, are not able to survive in the hospital systems for very long. And I said to him, so what's the answer? Why isn't it everywhere? And he just stopped And he said one word: leadership.
Mhm.
That was his response. And he told me a story when he was sitting in front of a C-suite. The CEO of a large hospital system had called him in and said to him, Eugene, I've studied your papers, I've studied your books, I've studied the examples. I want to do this here. Will you work with me? And Dr. Litvak turned to the CEO in front of the entire C-suite and said, no, I won't. And the CEO was shocked. And he said, I don't understand. Why won't you work with us? And Eugene turned to him and turned to the other EVPs in the room and said, you know, I see a lot of smiling faces here, but I've been doing this for a long time. And I guarantee you that one of the people in this room will make sure that what I'm doing won't happen. They won't stand up for it. They won't fight for it. They won't have the courage. And it'll be sabotaged. I've been in this movie too many times to just agree to do it again. And he said, and Eugene has a phrase, he says, it's kind of like cutting through cream cheese. There's no resistance, but you don't get any slice. And that really kind of typifies it, right? That's a great. Eugene is Russian, and maybe it's a Russian saying, I don't know, but he then, he looked at the CEO straight in the face. He says, there's no amount of money you could get me to do this work here. And the CEO wrote down something on a piece of paper and handed it to Eugene. He said, that's my cell phone number. I promise you, if you run into any trouble with anyone here remotely involved with not helping you, I want you to immediately call me on my cell phone and give me that person's name, and I will take care of it. I promise you. And he turned to the people in the room and he said, you don't want to be on the other end of that phone call. I promise you. And then he turns to Eugene and he says, now will you work with us? And Eugene says, yes. And he worked with them and he had a successful thing. I think leadership, we could talk about a lot of things, and we all do, about what we need to do in healthcare and the changes from, I think, the mosaics that we were talking about to the big things, to the incentives, to the payments. For me right now, and this speaks a lot to what all of you are doing, and Todd, I think to, you, what you're doing in particular, I think the core issue right now in healthcare is leadership. We need a different type of leadership. And Todd, to your point, it can't be in isolation. We have to come together. And we may have our different approaches, and we may have our different focuses, but I do think there's a unifying theme that we could come around, or unifying things that we could all come around. I think if we don't unify with this new form of humanistic leadership, I just don't think we'll be able to turn the ship around.
I so
Well,
agree.
make a comment about leadership. We have to understand that, what do we mean by leadership? Because even though somebody holds the title of CEO, COO, they also answer to people. They answer to their corporate or regional headquarters. They answer to their board of directors of the corporation, who in turn answer to the LLCs that have invested in them, that are keeping them on the market. So I think we have to, you can be a very innovative CEO, but if everything you're willing to accept has to fit into not touching the profit margin that's being established and expected, it's going to make your job pretty difficult.
And Zeev, what you just identified was on my mind as Adrienne, you shared that we have for however long been working on safety, quality, patient experience, but we're not moving the dial because we don't look at these. We look at these things tactically and as if there is a check the box and done, it's solved, and it's not. But the reason why we're not moving forward is those who are in the C-suite or the leadership don't seem to get it. Even though there's mountains of research to support it, there's always pushback and argument. And so we're not moving forward. So I guess my question to all of you, because we're not going to magic wand solve people's leadership skills and abilities and or get rid of the current and put in the leadership we need. Can we battle that? Or do we need to do something different in order to uplift what is needed? Because we've been battling the senior leaders for years. Yes, Lonnie.
I just add, because there's a significant thread going on in the comments around this issue, as well as it relates to, I guess the way I'd frame it is, we talk about, that everybody recognizes the need for change in healthcare, but is there really a want to change in the existing system? And there are a lot of guardians of the status quo who, so it's not always an issue of maybe the C-suite doesn't get it, but maybe the C-suite has reasons to resist it. So it's not an issue of understanding it. Or what Zeev was commenting about, Eugene Litvak saying somebody here is going to sabotage this, it's inevitable. I guess the related question may be, what is required to, first of all, call out and address, the elephant in the room of those forces and reasons for that resistance, and how to change that part of the conversation.
Mhm. And Adrienne, I've heard you say before that you're unsure that they really want to change, meaning those who are leaders within healthcare.
Did I say that?
Yeah.
I think I have a stream of consciousness. One is related to maybe sort of how our history informs the current. So when I was in medical school, I learned very early on some important lessons. I remember being in a class and they said, you know, let's open the table and just talk about things that are really uncomfortable. You're going to have patients that have things that are hard to talk about. What do we think hard to talk about subjects are? And of course, there was like 8 minutes of silence. And I said, I don't know, it's going to be hard to talk to patients about sex. And the teacher actually called me after class and told me that because I had brought up sex, that I was being disrespectful.
What?
And I said, I don't understand. You invited the conversation. You asked us to talk about things that were uncomfortable for our patients. I mentioned a topic and it's uncomfortable for you. And I get the backlash. And then later in my training, one of my first patients died and no one said anything about it. And I had never seen a patient die before. And on another occasion, I was, I think when I was applying for residency, I had written a very personal essay about trauma and my family, and no one read it because nobody asked me about it except the one person, which was at the organization where I went. They were asking me clinical questions, but nothing about the human part of. And so I only say that to say, so what I learned as a young physician was to keep my mouth shut about highly emotional conversations and that it was not safe to speak up. So let's hold that for a second and then contrast that with, I think part of leadership, part of the mandates of leadership is to create psychological safety. Ton of press about this now. But I think if we're asking honest questions of ourselves, you know, how many people have spoken up in respectful ways, contrary to a person in a position of power in these organizations, and been embraced and welcomed and invited to continue to do that? I think that answer is hardly anyone I have ever met in my whole life. And so it's not about being a rebel without a cause, right? It's that it's about having the greater good, having the desire for change, having good intent, and being respectful and thoughtful about how you use your voice. And quite honestly, I had to pose the question, are we really interested in that? Because many people I talk to, that answer is no, just please stay in your lane, go back and be quiet. And we've got this figured out. You don't step over here, and please take your strong personality somewhere. You know, and that doesn't move us like a vector forward in a particular direction. And I'm worried about that for a lot of my colleagues who are hoping to use their voice for good. And I'm seeing some nods on the panel, so I'm curious how others might react to that. But that breaks my heart a bit.
Yeah, I think it's, go ahead, Zev.
No, you please.
Well, I was going to say, I think it speaks to that culture of fear, you know, for a whole multitude of reasons. And many of my colleagues, it's related to the quote unquote golden handcuffs, you know, that large debt burden where they're afraid to lose their job, their income, how it'll affect their family, and so on and so forth. But I think the reality of it is there's lots of ways to participate in these movements beyond just your voice. Like, not everybody is willing to tell a VP of the physician group that they don't care about the fact that he was threatening my paycheck. And I literally told him to his face I didn't care. That, you know, that's going to be the minority. And we need those individuals, right? But the rest of us can do something, whether it's donating to a specific cause that's working towards a goal, whether it's connecting somebody who's struggling perhaps with the coaching and all these other things. And I think this comes back to a big part of what's trying to be accomplished with this group is that connectivity with like-minded troublemakers to feel supported and to have, frankly, to have the courage at times to push back. Interestingly enough, you know, I pushed back in quite big ways, and you can read about it in the book. Some of it was good, some of it was passive aggressive, and I probably learned from things like that. But all the people in the C-suite that were involved in that toxic culture, they're gone. And I wonder, would that have happened sooner if it wasn't just one or two of us speaking up, but hundreds of us speaking up or sending emails to that effect, or emailing the board, perhaps? You know, it's hard to say. So maybe that was a bit of a long-winded answer, but I think that culture of fear holds people back. But there's other ways to be supportive, I guess, is really what I was trying to get at, you know?
I think one of the things I just want to pop in and add, because there's so much negativity about leadership. And I have to say, I firmly believe that the majority of leaders are doing what they know to do. They don't know otherwise. They were raised up within this same system. And so how do we help them to have that light turn on, to recognize what they're doing, their awareness of their actions and behaviors, but also that there is a different way that they can and could do? And how do we help them to learn other, not just bash them?
Mhm.
Well, you know, I spent a lot of time looking at leadership in healthcare because it was one of the things I had to adapt in the model I'm talking about. And to me, the only one that really made sense was an interdisciplinary council of providers who understand healthcare. We're not, you know, you have to have business advisors. I get that. You have to have independent, I think, accounting oversight of what's going on. But it really should be the providers, I think, as a interconnected panel or council that are making these decisions, whether it's staffing ratios or distribution of resources or what do we mean by access for community X or community Y? Because we're really the ones that understand ourselves, understand what we can bring to the table. I do have troubles when it's MBAs making these decisions, you know, and I'll give you an example. I was a director for a telemetry unit in a very high acuity hospital. And I started doing my own staffing for the next day by limiting them to 5. They were giving these nurses 7 patients to start their day and then pulling PCAs off the floor. So I went to the CEO's, well, I got called to the CEO's office to explain why I was doing this. And I took, I don't know, maybe 10 studies with me that had shown what Zeev was talking about earlier, the outcomes and all of this. And I put it on the table. He never looked at one of them. And he says, John, we have the matrix and we have insurance. That's why we have insurance. And to me, you know, that is just so callous.
Wow.
You know, it could be your mother, your sister, your wife, your child in there. And there just seems to be no awareness of this at that top level in facilities. And that's really troubling to me.
Yeah.
So I'm going to pause the conversation after you, Zeev. Go ahead and say what you're going to say. I just want to allow Lonnie to bring in some of the chat.
Yeah. Yeah, that's actually, I was going to do that because I've been reading along and following along. There's so many good comments and questions here. So just thank you everyone for just contributing in this way. I think, again, I'm trying to bring what I'm reading as well as what I'm hearing. You know, I do think, so first of all, I do think conversation is critically important. You know, again, that's the way change happens, right? I mean, the founding of our country was a conversation. In fact, many conversations, many contentious conversations, where most people didn't agree with each other. And yet, you know, that's, you know, it really sparked this country. So I do think this is important. I think to what Adrienne was saying, and this is, you know, the question is, really simple question is, what can I do if I really want to change the system? And again, it's a really good question, which is, you know, with all the constraints and again, I need a job. So it's not like I'm independently, you know, if we were all independently wealthy, we'd be having a different conversation, right? But we're not. And so, you know, the question is, given the realities and constraints, you know, what can I do? And I think that asking that question and then collectively, and this is what I hope this conversation, again, I hope the work John and Todd and Adrienne and you know, Lonnie, I hope the work we're doing, this is where it can get very real, is to really provide each other's with answers. Like here is what, you know, if you're interested in policy, here's what you could do. If you're interested in primary care, here's what you could do. If you're interested in senior care, you know, someone was talking about dementia, here's what you could do. I think if we could create collectively possibilities, real possibilities for what people can do. And you know, and I think to what Adrienne was saying before, and a couple of others, you know, were saying is, not only can you not boil the ocean, but it doesn't make any sense to boil the ocean. It's like pick I mean, even if you pick something small, but here's what you can do. And then I think those, Todd, your ripples of change are, I think, spot on. It's like, if we start to get enough of those small changes, I mean, enough, a lot. And when we you know, because I think most people in healthcare, including the leaders who are making a lot of money, I think fundamentally they want to change the system too. I really do. I've just seen that so many times. They're trapped as much as anyone else. Like you said, Todd, before, they're trapped by the golden handcuffs. Some of us are trapped by brass handcuffs, whatever. But, you know, but I do think if we could provide answers to that question, if we could come up with answers, it's almost like a resource of like, you know, here's what you can do, whether you're a nurse, a doctor, a PA, you know, a tech worker, a vendor, it doesn't matter. Whatever position you're in, you can do something. I think that to me would be a really powerful catalyst. And I don't think that exists yet. I know I get asked that question all the time. You know, Zeev, what can I do? I'm just a fill in the blank, right? And I believe me, I've heard CEOs of multi-billion-dollar healthcare systems ask me that question, literally. Ask me that question. And I'm standing there dumbfounded.
I've got one answer. They could support Prescribe Hope to try and get these safe haven initiatives out there. And I say that joking a little bit, but I'm also somewhat serious, right? I mean, that's an ambitious project where we think it has the potential to activate millions of people in the right way. And that can be very powerful. And I know, Denise, sorry, I didn't want to interrupt the break here. And I was going to ask if there's a bio break component to this too. So.
I did not consider that, Todd. I'm sorry. Lonnie, I haven't been able to read it because I'm so engaged with the conversation, but I can tell that the chat is very busy. Any specific things you want to pull out?
There are so many that it's hard to even touch on all of them, but I will add a few points. One is there's quite a bit of discussion about the culture of around medicine training, medical training, and how that goes to each upcoming generation of providers and what they're taught. And then the issue of learned helplessness, which is a big challenge because that goes to the issue of, well, what can I do? I'm just one person. And then everyone then adopts the assumption that they can't do anything or that nothing that they do will make any difference, which is kind of what we're even trying to build with Healthcare Reinvention Collaborative is, to flip the script on that idea and understand that we can do more than we think we can, and the ability, and it goes toward what Todd, what you've written about in your book, and those ripples of change and all of the dynamics around that. There's a lot in the chat about what to do about that. There's also the type of training. There's in medical training, and I'm just going from what's in the chat. This is not my personal views. Lack of any training on real communications for providers with patients, or not a significant focus or emphasis on that. No training on issues like motivational interviewing, no training on DBT, no training on things that not only allow for a better opportunity between providers and patients to have meaningful relationships and conversations, but even how that applies to conversations with colleagues, conversations with superiors and administration and the people who you might feel are blocking you. So I don't know if there's a specific question I'm posing around that, but there's quite a bit in the chat talking about those issues.
Adrienne, I saw your hand go up.
Sure. I'm happy to take it all on. I love some of the questions. I want to address maybe 3 things that you brought up, and I'm going to try to remember them in order. The first is your last, which is training. During my time as Chief Experience Officer at the Cleveland Clinic, so prior life, we built out specific training for clinicians and then all caregivers about how to do service recovery, service excellence, but also build relationship through your language. That eked into the med school training. The issue, though, that I see is adult learners learn when they repeatedly see the same construct over and over again, and it's relevant to their context. So as a med student, if you've never had somebody die, you can train somebody in how to have a crucial conversation all you want. But until they're in that situation, it's not relevant. And I would argue that they don't learn the skill because they're not routinely practicing it in real life setting. And so I think I worry, we hope if we dump all the training actually in, I would argue a lot of the training is perhaps ineffective or less effective than we think, because it's not reinforced once they go out into the real world. There's very few hospital systems or organizations that I see reinforce that training. And that's where it erodes and just falls off. And in fact, what we found is when we use that platform to train, we actually healed a bit of each other because there's nowhere else for that suffering of clinicians to go. This was a shared facilitated conversation we could have, which has been shown in multiple studies to reduce burnout, both in our work, also at the Mayo Clinic and subsequently. So investing in actually training people to use their words for a relationship can be incredibly therapeutic and drive the outcomes you want. Second point, we haven't mentioned yet that it's not just the people doing the work who can solve it. I haven't heard us talk about patients and communities yet, who I do think are co-designers with us. And I just want to make sure we call that out. The third is about, I think one of the things we can do, I love Zev's point here, which is you have to take back your locus of control. Okay, when I have felt out of control in my clinical environment, when I have felt out of control as an executive, I anchor around what can I control? And I have landed, and I just suggested as something for people to consider, that we have to know where our own joy comes from. And actually, one of the most important strategic plans I came up with was a strategic plan for my next 10 years. How I was going to derive joy in my legacy and impact, because that's under no one else's purview, that's mine. And I began to think of that in layers, right? I can impact the person in front of me today. I can connect with a colleague who I know is struggling. Right? One-on-one. Then I can do something for my team. I can make sure I'm leaning in, showing up for conferences, teaching, sharing what I know. And then nationally, organizationally and nationally, it goes on. And, as I travel the world and visit with organizations, I'm trying to make sure that my locus of control there is to amplify the best practices I've seen everywhere. And in the one-on-one interactions I have, to model the humility and curiosity that I am asking them to have for each other. And so I like to think about it in those layers. And I agree wholeheartedly. Every one of us has a locus of control, but some of it is taking it back. We keep sort of externalizing it. And I would challenge us, even in the chat here, I see people saying, oh, it's the doctors. Oh, it's those evil leaders. Hey, guess what? That's us. That's us we're talking about. And so I want us to model in this conversation the same empathy and curiosity. What can I learn today instead of just putting my point forward? What could I learn about what I could do differently? That would be my challenge to some of this dialogue.
And I'll chime in about the doctor and the salary part, I suppose, a little bit. My salary last year was zero. Zero. I'm doing what I'm doing because.
Uh-oh.
I think we lost.
Frozen.
Frozen, yeah.
Yep. Shoot.
While we're waiting, Adrienne, oh, there we go. Okay.
There
Todd,
you are. You froze.
You froze for about 20 seconds.
Dang it. Sorry.
You're doing what you're doing because.
Oh, man. It was really getting good, too.
It's important Todd, everybody realized it.
I almost stood up for a second there, John. No, the reality is, as I was saying, I didn't make any money last year, and I spent hundreds and hundreds of hours working on things that I believe in, including connecting with all of the people here. It breaks my heart to see the deaths by suicide. It breaks my heart to see my colleagues my age walking away, and not wanting to do this anymore. It breaks my heart to see physicians going through medical school and having no plans to practice. This is not sustainable. And there's a couple things I wanted to add on. I wanted to go back to the learned helplessness. It doesn't need to be that way. Smile, thank a coworker, write them a card, give them a hug. Those are simple things that everybody can do that can be so powerful, that might make all the difference in the world. That's the power of 1+1. And obviously, I'm a huge believer in getting the patients on board with this. For goodness sake, my +1 is a patient, Joshua. And I texted him the other day. I said, Joshua, it's almost surreal, like what we've been able to accomplish, or at least what I think we've been able to accomplish as a doctor and a patient. And so we need that power. We need that side of the healthcare landscape joining forces with nursing and physicians and everybody in this room. So those were just a few of the comments I had, and hopefully that resonates.
John, you were trying to say something.
Well, I just want to go back to what Adrienne said about the community. To me, it's much even bigger than that. It's, not just the community health workers, but most of the healthcare in this country is given by family members. We have to include them in the circuit. We have to include the community health workers, the public health nurses, the nurses' aides, the people that come in to, take care of grandpa during the day, long-term care facilities. All of these parts of healthcare have to work together so that we're able to not just go into a community and say, here's what we have, what do you want on menu B, and go in and try to find out, what do people need? And then how can we meet those needs as a health system, even if we have to bring in other resources, the Department of Agriculture or marketing things. We have to start understanding that the health of a community is not just the disease load. It's also the sense of opportunity and participation and access to resources and things that we enjoy in suburban and urban areas, but which in a lot of this country is not. One of the articles I read was talking about how physician or medical students are actually dissuaded in med school from going into general practice, that it's seen as some kind of low-level subservient role or something. And then even when they graduate med school, the fight for the limited residency spots that are out there has just become traumatic. And Texas was complaining, for example, the Texas Medical Board, that, even though we have med schools, they come up, they can't get residencies in Texas, they leave, and then they never come back. So, there's multiple levels of things we have to address, I think. Student debt is one of them.
Well, and I often say that what we're seeing in healthcare is indicative of what we see in our society. It's not in isolation.
Mm-mm.
So I would love to go to those. We have individual questions for each of you. I'd love to be able to shine a light on each of you with the questions that we created and see how far that gets us. So Zev, you're first in the list that I have here. And so in your book, Reframing Healthcare, you advocate for disruptive change. And I'm curious, what are those that you see who are disrupting healthcare asking? So how are they looking at the problems differently to raise new questions and thus identify solutions?
So I'm gonna answer that or respond to that, taking in all the conversation we've had. And it does, yeah, just the comments on the people are writing and what Adrienne and Todd and John and you and Lonnie have said. I do think that I think this issue of doing what you can within your locus is probably the most important message right now for lots of reasons. One of which is if we all do that, it is a ripple of change. It's more than a ripple. It becomes a torrent, and it becomes a movement. And, and the thing about that, about taking action, and this is what I've seen, all the folks that I've interviewed, the hundreds and hundreds, they're doing something. They're not talking about, someone said before, they're not talking about the problem. They're actually creating a solution. And I think there's something that is very, very affirming about that. The minute you start to act, it changes who you are, and it changes how you think. It changes your chemistry. It changes your physiology. It changes how you feel about life. And so I do think what Adrienne said was really important, that locus control, no matter what it is, no matter how small it is, right? Stephen Covey said that, decades ago, that, if your locus is a tiny dot, but you do something, that locus grows. And as opposed to thinking, well, what can I do that's outside of my locus? Then your locus shrinks. So I think action is really, really, really important, no matter how small it seems. Even the notion, I mean, I had a conversation this morning with the chief medical officer of one of the most prestigious healthcare systems in the country. And, it was really interesting. She's in the middle of her morning, in the middle of her work, calling from her office in this healthcare system. And, all we did was have a conversation. But at the end of it, she's like, Zev, I feel so empowered. I'm going to get up from my desk and I'm going to do something right now. And I was like, wow. Okay. And I was part of her doing, and I feel, and to me, she said, you've energized me. And I said to her, no, you've energized me by what, I don't know what you're going to do today, but whatever it is, I'm already feeling that. And here's where I am right now. And I'll end with this. Here's where I am right now. And this for me this is really sort of the cutting edge. I'm pushing it here, but I have been studying people's actions and their mindset. And there are two mindsets. There's a status quo mindset. And I'm not talking about people. I'm talking about a mindset, because every single one of us has a choice in every single moment of our life, literally in every single moment, to adopt a status quo mindset or what I'm calling a humanistic rebel mindset. And I think and I know this speaks to what you're thinking about, Denise, and talking about, given all the isms around us. I mean, this is just, without pointing fingers, without blame, we live in a world that has racism and sexism and ageism and ableism and industrialism and classism. That's just the reality. The question is, what are you going to do about it? And I think you fight it with humanism. And that takes a rebel leadership mindset. And so I've been really, really thinking about this a lot. And more than thinking about it, I've been writing, journaling about this. Tomorrow, I am going to put out here's a status quo mindset. This is what the actions of a status quo mindset. This is the actions of a humanistic rebel mindset. And by the way, I was inspired because I've been speaking to dozens and dozens of groups across the country over the past few months. I mean, like dozens. And I've seen both mindsets in actions. I've literally sat with a group, and this is what inspired it. I sat with a group about 2 months ago, and I was like, oh my God, you're a bunch of rebels. And I was like, but you're not just rebels. Like what Adrienne said, it's not rebels without a cause. You have a humanistic cause, but you're rebels. And so I started to document that mindset, and I'm going to share it in my newsletter tomorrow morning. I'm going to share the actions. And I do think it's really, really important. This is not nothing. This is everything. The question is, at every given moment, what is my mindset? Am I going to be despairing and despondent and disheartened and, woe's me and blame and have that victim mindset? Or am I going to be a creator? And no matter how small it is, no matter how tiny it is, if I do something that is positive, and to what Adrienne was saying, that brings me joy and makes, and I'm enthusiastic about it, no matter how small it is, I think you can consider yourself a humanistic rebel leader in that moment. And, and that's what we need more of.
Now that's a mic drop, Zev. That was great. But I want to open up. John, Todd, Adrienne, do you want to add anything to that before I ask another question for a panelist?
I was
you know,
hoping we didn't have to follow that.
I would
That
add
was so
this,
good.
though. I would add this. I don't think that some people, for example, are just victims of their situation. So, for example, if I live in a smallish type town, there's one hospital, I'm a registered nurse, I'm a single mom, I've got 2 kids. There is no way I'm confronting the CEO leadership of that hospital. I'm going into work every day going, I cannot be fired. And if you're basically of the mindset already in that profession that you're, I don't want to say powerless, but you really don't have much of a voice. And I can understand why a lot of providers just draw back. They don't want to get involved in the bigger battle. So to me, the power we have is strength in numbers. So, if medicine and nursing and PT and pharmacy and, occupational therapy, and if these groups came out unified behind a vision for healthcare, for transitioning healthcare, I think that would be an incredibly powerful message to the American public, which is what you're going to need, in my opinion, to overcome the hundreds of millions of dollars that are going into the political system from those that are entrenched and don't want to change anything.
Another mic drop moment. No, you're right. You're right.
All right, Todd, you're up. Mic drop.
No pressure.
I'll just patiently wait for my question.
Well, since it's been queued up, let's ask it. So Todd, as a physician who stepped away from patient care to write a book with one of your patients, and you're identifying the challenges in our healthcare system and advocating for our quadruple aim, what questions were you asking of yourself as you made decisions and redirected your efforts to disrupt healthcare?
So I guess to start, our quadruple aim is patient experience, quality care, lower costs, and provider wellness. And I think when decisions are made using that as a framework, magic can happen. And I've seen it at everything from the office level to the hospital level. So I think that's important, that the audience understands that framework. But I think the question, when I read that question, Denise, my mind went in a couple different directions. I think twofold. The first one was, 10 to 20 years ago, I would have encouraged my children to go to medical school. I would not do that today. And I love being a doctor. Okay. And I don't want to go down that path, because I think the better answer to the question goes back to a time after I survived burnout. And forgive me if I get a little emotional talking about this, because it's still painful at times. I remember sitting in my backyard in tears, hating the job that I loved, hating it. And I questioned everything at that time. I questioned my sanity. I wanted to quit. It was horrendous. And, perhaps the word burnout's been sensationalized or overused or whatever you want to call it. And I'm a big advocate for moral injury as well, building up to burnout, if you will. Having lived it and gone through it, it is a visceral pain that is hard to describe. To be going to work angry, to not giving your best to patients. And so that was a major driver to writing the book. And thank God there was some catharsis that came along with it. It took a good 2 years for me to really feel like I was back to normal and feel like this leader I felt like I once was. I was broken, absolutely broken at that. And fortunately, Joshua was also broken as a result of the medicine I gave him, which is a whole nother, you can read about it. But, that power of the two of us coming together has spurred me on to want to shake it up in a big way. And it's with people like this that I feel like we can. A Medicine Forward one, it's in the healthcare reinvention collaborative. It's just incredible. And so that I think is the answer to that question. That's what encouraged me. That's what inspired me. That was the why. I wanted to be able to tell my children one day that it's okay to go into medicine. I want to leave a landscape that I'm proud of. And I don't want anyone to have to experience burnout, because it sucks. So with that, I'll stop. Sorry, start crying.
Todd. Stories are so powerful. Stories help to connect us. And thank you, Todd, for sharing that. Now, Adrienne, I don't like the question that I created yesterday. I'm curious because you said you came with other questions. Do you have another question on your list that we should be asking?
Yeah, I've got 18.
Excellent. Go for it.
But before I do that, I just want to say, in reflection of some of the things I heard and Todd and his vulnerability, I think even to the point we were just discussing, making a choice on a international, national, public webcast, podcast, whatever you want to call it, to be emotional and share part of your story is a choice. And that is one way. We have the ripple effect I think you so strongly advocate for. And I want to thank you for your courage, and also honor the heartbreak of what it is to be a healer and want to be a healer and be in an environment where you can't be that. Right. That's the definition, I think, of some of the moral distress that people cannot survive that John was speaking to. I'm going to take a deep breath and try to transition to my list of questions. Oh, I froze. Am I moving now?
You're moving.
Okay. All right. Well, here goes. I'll throw some out and see how they land. One is, why is humanism and humanity and love and words that have emotional context, why are they not on executive teams? We're very comfortable with words like value-based care and medical operations, and we will drive clinical improvement.
I can answer that.
I think it's a rhetorical question around.
Yes, but I'll tell you what it's important. I see.
Hold your thought. Hang on.
Yes.
I think that I would really love to see these conversations. And I know to the point that was also raised, I think we have beautifully intentioned leaders. And I think growing in comfort to talk about emotion when we talk about errors and our own failures is part of how we create room for innovation and normalization of the emotional business we are in. And one of the things I learned, I'm a huge fan of learning and actually have derived a tremendous amount of growth and I think personal joy in learning from others, but huge fan of improv. And one of the things I learned when we were studying improv was a failure bow. And this is a notion that when you fail in a skit or a performance or in a work job, you're supposed to stand up and say, I totally failed at that podcast. I didn't give credit to the 18 people who actually wrote the book with me. And I'm so sorry. I was so nervous. I think I really lost track of time and didn't get a chance to honor everybody else. And then you take a bow and everybody in your community is supposed to break out into applause. And then you stand back up and move on. You let it go in the moment. You've created a moment to honor the failure, to talk about its impact on you, to talk about its impact on others, and you move on. And now some of you may be listening going, well, that would never happen at an executive team. That would never, and I've never seen it happen on an executive team. I've never heard anybody stand up and say, oh, I failed yesterday. Let me tell you about why that didn't work. Let's do a, what do they call it at Stanford Executive Ed? A post RCA, to understand why did we fail and fall down? How did it make us feel when that happened? What are the learnings there? And then how can we go on? So maybe another one is, should we have some failure bows to normalize the emotion that happens when extraordinary humans fail, especially in the care of other extraordinary humans? And what would that do to get us to embrace failure and the emotions attached more normalized?
Yeah. And Adrienne, somebody else who I know very well, who is also, he leads improv, and he taught me to celebrate I failed because it meant that you risked something. Yeah.
Yeah. It meant, we're talking about transformation and innovation, right? Like, by nature of that work, you are doing something different than has been done before. The path is not paved. You are stepping out. You are positively devianting, to steal the words. You are brave and courageous and forging your own way. And that inherently will involve failure. And nearly every entrepreneur, I heard the chief transformation officer of Uber talk not that long ago. And he's like, yeah, sent teams out. They all failed. Only one, it's rare that we succeed. And what would happen if we were more comfortable with that?
Yeah.
When my daughter was,
please recognize, I'm not talking about innovating on safety practices. I'm talking about spaces that are safe to innovate in.
Lonnie?
I was just going to interject because it's right on point to what Adrienne was talking about. When my daughter was 6 years old, we enrolled her in a class that I can only describe as self-awareness for young kids, even though that wasn't the name of the class. And one of the precepts that they taught the kids was to celebrate mistakes. You know, like, I made a mistake, yay!
Yeah.
That's something that, you know, we don't teach children. In fact, we kind of indoctrinate ourselves and our kids for quite the opposite. And in medicine, even more so, a mistake can be life-threatening. And so, A, you don't want to make one, but B, if you do, you sure don't want to spotlight it. But that creates burnout, that creates barriers, that creates people leaving the profession. And we don't, if we aren't raised in that environment, and then you're put in a stressful situation in your career, what do you expect to happen?
Yep. So I want to give John a question, and then we're going to again open up to our audience. So John, the question that I had written down was, you proposed a sustainable economic model and specific goals to improve public health outcomes. And I'm really curious, what were you asking that helped to elevate the model that you've proposed?
Well, I think after the development of the goals, I think it was going down each one of those goals to see, you know, what would be operationally most effective in attaining those goals. And one of those goals was cost efficiency, because whatever we set up, we don't want it to be the money pit that this is. And when I started looking at that and reading things like Uwe Reinhardt in the articles that have been written in the past, I came to the conclusion, and at that time I was doing my MBA work at Tulane, and I was working with a couple of economists, and we started talking about this. And what we found out is we actually have zero idea what the actual cost of healthcare in this country is, because the only thing we can really evaluate it by is how much the federal government is spending out, and then what they're charging in the facilities, which is completely detached from the reality of what that service would actually cost. So when we did our analysis and implemented what we were talking about here, we saw a 42% reduction in cost, which is a huge amount of money, but it's getting rid of a lot of the fabricated pricing that's developed over the last 40, 50 years, because there were absolutely zero constraints on what they wanted to charge for things. So to me, it always leads back to understanding these goals and going down these goals so that we're addressing, for example, what do we mean by access? If we say a community should have access to healthcare services, what does that mean? We can't build a trauma hospital every 50 miles in this country. Distribution of resources. What resources? To whom? Where? You know, how is it going to be led? What is the most cost-efficient way to deliver that? The administrative team was another issue. You know, how do you administer a health system on a statewide region unless you're doing it through the voices of the providers and the practitioners that understand what their services can and can't do, and the most efficient way to move those services and deliver them to, so that every community is covered. And to me, that's the arguments I have against direct primary care and value-based care, is you're asking people to pay more so they have access to primary care, but they still need major medical because that primary care physician can't deliver, you know, a kidney transplant. So to me, we have to go in with the understanding that we're talking every community, everybody that's living in the US. And if COVID taught us anything, it's how interconnected we all are and how fast it can go into the hopper if we're not paying attention, and we don't have a health system who is paying attention, aware, and can respond as a system.
Mm-hmm. Thank you, John. Yeah, each of you did a really good job of drop micing. Good job. So what I do want to do, Lonnie, is go to the chat. And I know that we did ask somebody to hold a comment. And so whether or not she would like to, or maybe she put it in the chat and you can share.
I'll just ask Ethel to go ahead and unmute and add your point about the left brain, right brain.
Yes, few people know about that. And actually, the profiler that I mentioned in the chat box, Team Me, will exactly tell you how much of your left brain and right brain you're using right now, which is important because this whole conversation has been from the left brain. Only Dr. Otten was able to reach everyone, but made them very uncomfortable because we are stuck in our left brain. Fortunately for the work that I do, I have 60% of my brain that is in the right brain and 40% in the left. It is the people with the right brain that will save this world, not the left brain. And that's why when Dr. Adrienne spoke, I felt very emotional about it, because it's difficult for doctors to go to the right brain. I have doctors on my team. I invite them every day to do that. It's so important. What do you have in your right brain? You need to know the difference. When you ask a patient that's suffering, tell me on 1 to 10, how much pain do you have? You're in your left brain. Instead of saying, I see the pain that you're suffering, I'm sorry, tell me about it. Before you ask after that's done, the emotion goes to 0. Now you can ask your question. Do you understand? That's all part of learning to communicate well, being a better doctor, being a better practitioner, for me to be a better leader at the ICA.
Yeah, you're, as a neurologist, you're,
Mhm.
I would argue we need the whole brain. But
Mhm.
but I agree with the point that, right, 75% of decisions that people make are made based on their right brain and emotional decisions. And there's a tremendous amount of literature that certainly supports we're missing emotional cues in clinical visits. And there's ongoing opportunity. I think AI will recognize emotion sometimes better than we do, but let's not veer too far off in that direction.
Mhm.
And evidence supports that. That said, I think your point that I'm hearing, and I also want to +1, is that what's the phrase, suffering doesn't have a single owner. We are all carrying suffering in some form. And again, I'm going to ask for empathy and curiosity for what is happening in our environment such that our clinicians aren't asking those questions. What is happening that they don't greet people as people and talk about them as room 5, bed 13, the 1 o'clock patient? There's I would argue, and I think most of the burnout literature supports, this is a system problem, not an individual problem. This isn't about Dr. Todd or Nurse Nancy or Nurse Joe, and this is about a system that dehumanizes extraordinary people. And I would tell you, I think this study of people that continue to thrive in those organizations or continue to find their way to fight within it are the people I'm most in awe of, because I see them everywhere. And maybe they're part of the 450 that Zeev has talked to, but I also think they're the ones on this call and in the organizations that you've seen others reference and create. And that sometimes on my darkest days is actually what keeps me going just one step, because I worry I don't have the impact I want to have on the world. And then I anchor in, it's not about me. It's about the work and how can we get others in a community rallied around that. And that is always worth sort of fighting for, protecting, advocating for, making one choice every day that I can move just a little to the right. I can make this person feel a little bit different. I can bring my whole brain to this conversation. And I'm up for that challenge.
There was a comment in the chat about the pressure cooker that people in healthcare feel all the time. And when you're in that kind of environment, if you're communicating at all, it's mostly in your own head in terms of what the pressures are that you're feeling and what happens next and what do I need to do now. And so listening becomes very challenging. And I just want to share a 1-minute anecdote. I had a outpatient procedure yesterday in an endoscopy center, and I was in the holding area before you go into a procedure room, and there's just a curtain separating where I was from the next person in the next room. And you can't help, I mean, privacy is not really, the curtain doesn't create privacy because you can't not hear a conversation that's going on, 1 foot away from you with a thin curtain between you. And the doctor came in to do the prep conversation with another patient, and I could hear as the patient was talking and doctor's asking questions and checking, this is the thing we're doing today, and do you have any questions? I could hear that he was in his own head. I could hear that he was just trying to get through that so that he could address whatever the questions were and move to the next thing and get her going. And 3 minutes later, a nurse came into that same area, and there was an entirely different conversation where the patient was talking about what she was really feeling. And she had someone that she felt safe in and who seemed to invite that communication. So maybe those people just dealt with pressure differently, or maybe they had and felt different levels of pressure. But for sure, the system creates pressure, and most of that pressure is actually financial pressure, or it's driven by financial pressure that then shapes all the behaviors and the decisions. There's so much that's going on in that environment that I'm interested in seeing when the question was raised early in the conversation about, do we really have a healthcare system? Do we even really want a healthcare system? And what is that system? Whatever you might call a system today is struggling, if not failing, because of pressures, or it seems to me from a patient's perspective, because of pressures that I know are influenced by financial considerations. And I don't claim to have an easy answer for any of that, but I thought it was a valid point out of the chat that I just wanted to embellish a little bit.
You know, Lonnie, I had a chance to interview the chief experience officer of the VA and the National VA. And so it's really interesting. They have a trust survey. It's the only organization I know of in the country that actually asks their patients. Are there others? I'd like to, Adrienne, tell me who else, because so far it's the only one I've seen that has this trust index. So they ask 3 questions. Well, first they ask overall, do you trust the VA to take care of you? And then one question, the one is, it's ease, 3 E's. Ease, you know, do we make it easy for you to get your medications, get care, access, that sort of thing? 2, effectiveness, do we take care of the issues you wanted to be taken care of? Do we address them? And 3 is emotion. And, you know, did we treat you with respect and dignity, you know, and did we listen to you? And what I love about that is they do that every quarter. They've been doing it for a number of years. And then they post, this is the most remarkable thing. They post the data publicly. So you could go onto va.gov/trust, and you could literally see their trust index, and they break it down by gender and race, which is even more remarkable. Talk about building trust. But I think, Lonnie, to your point, they really focus on this issue of emotionality. And, you know, in a way, again, I haven't really seen elsewhere. And then what they do, though, is it doesn't end there. Then they take those results and they explore it with patients. Well, we saw in this last trust index that blah, blah, blah. And so they do surveys, they do focus groups, they follow patients, they do all these sorts of things to really try to figure out, okay, what do we need to do to change to bring that in there? I do think, Lonnie, that, you know, that what you heard and saw is not necessarily a bad thing. It may be that, you know, the doctor is not the right person to have the emotional conversation, to take a few minutes in time. And maybe the nurse is a better person or someone else on the team. And I do think that as long as the patient is taken care of, I mean, maybe the doctor is just a technologist in that case. And you know, there are other members of the team that are really taking care of the patient as a person. As long as as that's happening, I think is the most important thing.
Yeah, please.
I think maybe it harkens back. You're reminding me of the conversation that kicked this off. And I think it was John that brought up the great point of like, what is the end point? Are we all in agreement about is it cheaper care? Is it value-based care? Is it, you know, what is it? Is it retention? Is it loyalty? Is it trust? What are we after? And I do think part of the issue is there's tremendous variability in that answer. I don't see people agree. And what's really interesting, working for an experience management software company, right, that works with 18,000 brands, is that in every other industry, all right, the Deltas and the Starbucks and in every other consumer obsessed industry, they deeply understand the emotional context of their customer, whether that be the community, the patient, the customer, the employee. And that to me is fascinating here. Because if we don't talk about emotion and people are making decisions based on emotions, they're not only making decisions about, am I going to trust you and come back and get care from you? They're making decisions, am I going to take that med you told me to take, which we know half patients, if not more, don't, right? They're deciding between potato chips and burger and what you talked about today. They're making these micro decisions, I think, in every moment. And most of the time when I'm working with patients who have multiple sclerosis, there's something magical about the relationship I have with it's magic when they trust me. We have a shared goal. They do things that they wouldn't otherwise do. They heal me in ways, they care about me in ways that I never would have anticipated. There's real beauty there. And I want to sort of pull that out because I think the VA, I agree, has done a beautiful job. And there are many organizations sort of fearlessly running at, I am ready to listen to all parts of my population. And in the parts that I don't listen through traditional surveys, I'm ready to go talk to them in their communities. I'm ready to do design thinking at the bedside. So I see and feel enthusiasm for a new way of listening, which I think is a running start at understanding the emotion and effort and pain and joy that is in our systems that I have never seen before after being in this, for 25 plus years. And to your point, we haven't spent much time on it, but I do think metrics matter. Are we after repeat buyers of ER experiences? I was just in the ER and my answer is no. Like, that is not a product I ever want to consume from any practitioner. And yet there I was. And so I think our value equation is different. And I think really thoughtfully, I do think trust is actually the right thing to be asking, because it's fundamental to how we're making choices today.
And not just trust from our patients, but trust from the employees.
Oh, no, it's
Right.
layered,
Mhm.
right?
That's
Do you
right.
trust
Mhm.
me? Do you trust your team?
right.
Do you trust
Yep.
the organization?
Yep.
That's right.
Yep. And the bravery to publicly post.
Oh, yeah.
Yeah. John and Todd, we have just a few minutes left. I wonder if you both might have a last contribution.
Todd, go for it.
All right, let's see what I can come up with here. I'm just kidding. No, I just wanted to make one comment about possibly additional solutions. And this conversation, it's just riveting to listen to my colleagues with so many wonderful ideas and notions, and to talk about love and trust and the magic of the patient-doctor relationship or provider-patient relationship, whatever you want to call it. Again, I'd like to go back to organizations doing positive things, and I'm going to allude to a project that's going on with the group I just joined, ECS. They are developing what's called a right care clinic, which is a level of care between the traditional notion of urgent care and the ER. And the idea is those patients who are coming out of the ER that need close follow-up and can't get in with their primary care provider have an opportunity to go to the right care. Or conversely, those patients who may not need quite that level of care in the emergency room, but are a little sick and you're a little concerned about them, but they don't quite qualify for urgent care. This is designed to fill that gap. So it's a new endeavor. And I asked the question, because I'm the new kid on the block, all right, who are we looking at to follow at this? And they're like, well, we don't really have anybody that's quite doing it. We're kind of building the airplane as we go. And I'm like, I love it. Let's do it. And so I'm going to fill that primary care void in the group. And the point I'm trying to make is, it's okay, as Adrienne said, to take the bow when you fail, learn new things, and realize that we're entering some uncharted territory. And so I thought it would be really kind of cool to end on maybe a positive note of something that's happening out there. So with that, I will again be quiet.
Fantastic, Todd. And John.
I wish I had a big positive message. I invite everybody to come join us. We're an umbrella organization, and don't let the name scare you, nursestransforminghealthcare.org. We're transdisciplinary at this point. We've got people coming in from different countries. Our goal is to serve as an umbrella organization. We support Medicine Forward. We support any group that's moving toward a kind of a rational discussion of fixes, of how do we solve this problem of, and doesn't a free society have the right, I think it does in my opinion, to evaluate social institutions to see if they're working. And if they're not working, to implement the process to begin change. I think when we look at the cost of healthcare, we look at the outcomes of healthcare, we look at the impact of this health system on providers, I don't see how anybody can sit back and go, wow, this is good stuff. So I think as a country, we need to come together. We're in my organization just getting ready to go into the upper level public domain with national advertising. But that takes funding. And so of course, as a 501(c), that's always what we're doing, is we're out asking for money endlessly. But we welcome all support, all voices. Come to the meetings, make your points. Let's see how we can start building this togetherness that Todd talked about with all of us as providers, to see how we come up with this reconstruction of a health system, not a disease management system. And part of that's going to be including, how do we prevent diseases from happening in the first place? So, I was surprised to learn how many physicians never really got a lot of training in nutrition. And we can argue that nutrition is probably the most important part of health, besides what Zeev talked about, which is the social and economic determinants of health. So I think we need to, drop the hubris, come together. Let's get these different voices in there talking. Let's come up with a different model, let's say, for healthcare. And then as practitioners, as providers, come forward in some kind of unanimity to talk to the American public and say, look, what we have isn't working. This is our, opinion on how we could move in the right direction.
Thank you, John. So we have a few extra minutes, and I'm curious because one of the questions I've written so much down that I haven't been able to ask, but one that I have, if you were talking to those on this call or those who might listen to this recording or whatever else, what would you say to them to help them spark their inner deviant in the right way? But what might you share? Because our system tends to squash that. And so what final words might you make for those? Go, Todd.
You are not alone.
Mm.
There are a bunch of us out here. Just reach out. We will connect you. We will try and help you. We will try and support you. I've got a big mouth, so I'm happy to join in. You're not alone.
I think I would add to that everybody needs to realize that there's zero predictability in health and health status. None of us, the people on this call, none of us can sit there and go, well, a week from now, I'm going to be absolutely the same and absolutely fine. Between, the naturally occurring things that happen as we go through life and then the absolute crazy randomness of stuff that happens, I think people should realize that healthcare is a vital necessity. It's water, it's electricity, it's food. You never know when you're going to need it in the case of healthcare, but when you need it, you need it. And that capacity to deliver that health service has to be there for you when you need it.
I would add that your voice matters, but your actions matter even more.
And I think I would add that it's okay to do the hard work that's behind the scenes in support of those who are willing to use their voices. So you don't always have to be in the limelight and step out, but you can be in support of, and that's okay. Find those individuals that you can help lift up and do it that way.
Well, that's a really good segue, Denise, into what we're trying to build with Healthcare Reinvention Collaborative as well, because our goal is to identify and find those initiatives that seem to be taking hold, that seem to be getting better results, and to connect people who are interested in it or working on something similar, or just spotlight it, give it more attention, give it more oxygen, so that more people become aware of it and are drawn to supporting it, so that we don't feel like we're alone, and that we understand that while change can be impacted by the larger groups of supporters, those larger groups are made up of individuals, and each one of us has an opportunity to create the mindset that is going to be open or closed. And we're really, personally, I just want to thank everybody who was on the conversation today, including all the people who've attended and shared their comments in the chat, their voices, because that's really behind a lot of what we're trying to build, and we want to be part of, and we want to make sure that that people are doing good work that can be learned from, supported, and empowered are getting noticed.
And thanks for identifying that, Lonnie, because this wasn't a typical event for us. We like to talk with those who join us, not talk at. And so it's very difficult to ask people, we're going to actually ask you not to contribute verbally, but do so in the chat. And so, yes, recognizing that. And John, Todd, Adrienne, Zeev, thank you so much for joining us today, this conversation. I think we could continue to discuss it. There's so much more, but I think you sparked a lot of different discussion points that those threads will get pulled. And I think you likely really ignited individuals who are on this call with us to think differently and begin to think about pulling out their social deviant and taking some action.
Denise, I have this I have this little thing a friend gave me. It says, sometimes being unique and rare means, and it's got a picture of a unicorn, it says you have to resist the urge to impale others. So not a very empathic statement, but I think when you're asking for final thoughts, and I know you're trying to wrap in,
No, you're good.
a little bit about picking up your own internal signal.
Yeah.
If you're rare or weird or have been called a deviant or a rebel, there might be something magically unique about you. and then pick up the signals about your organization and figure out whether or not that's a space you can thrive and grow and impact. And if you can or can't, then I think making a decision to chase your own joy, find your locus of control, are some of the themes I heard from my colleagues today that I would pull out and sort of map your own path. That those would be some final thoughts from me, but really enjoyed the conversation. Learned so much from all of you. Thank you.
Excellent.
Thank you.
And Zeev, I don't think we gave you a final thought moment.
I'm just encouraged and grateful for, you know, everyone on the call. I mean, again, this is an example of everything it's like, it's not out there, it's here, it's happening. We're making it happen right now in this moment. I'm just, you know, all of you, you know, Adrienne and Todd, John, Lonnie, Denise, I mean, just so great to see you and hear you and hear what you're doing. And it's really inspiring. It's encouraging. It's heartening. And, you know, the same for the folks who hung in there. We're listening and writing on the sidelines. It's the comments are great. I almost feel like it would have been great to be able to read them, some of those comments out loud a little bit more, but just very, very grateful for this. Yeah.
Yeah, thank you. So yeah, the recording will go out to everybody. The chat thread will also go out, so you will be able to capture that. I know there are some links put as well, so we'll capture those. There will also be links to the excellent work that each of these 4 panelists have and are currently doing so that you can learn more about them. I did put a link in for Zeev's newsletter because he said it's dropping tomorrow and it sounds like it's going to have some stuff that we really want to know. So hopefully you grab that and you'll get that newsletter. Again, final thanks. I'm going to stick around if anybody wants to stick around. I'm happy to talk with you further, but I do understand that it's been 2 hours and you might just need to go for a bio break. Thank you so much.
Thanks, everybody.
Thanks, everyone. Thank you.